You know that feeling, right? When you're getting over a bad cold and your ear just suddenly feels full.
Oh yeah, that horrible pressure.
Right. It's that dense, muffled sensation like you're suddenly listening to the world through, I don't know, a wall of water.
Yeah, and nothing you do fixes it.
Exactly. You try yawning, you try holding your nose and blowing, you try chewing imaginary gum, but the pressure just holds. It stays totally stuck.
It's incredibly stubborn.
And, well, maybe it's not you. Perhaps you're managing a child who seems to be on a never-ending cycle of ear infections. You know, they're constantly asking you to repeat yourself, or they're subtly turning the television volume up to the absolute maximum.
Which is something so many parents deal with, yeah.
It is incredibly common. And clinically, I mean, we've almost always written this off as a localized mechanical plumbing issue, right? Like a viral infection triggers fluid backup, the anatomy fails to drain, and boom, end of story.
Yeah, that's been the textbook narrative for decades.
But if we pull back the lens, we might be looking at this entirely the wrong way. The fluid in the ear cavity might have very little to do with a localized viral infection and, well, almost everything to do with a systemic immune response to, say, the dust mites in your living room or the pollen outside.
It is a massive paradigm shift in otolaryngology. We are looking at a fundamental reevaluation of how the human respiratory system operates.
Wow, a fundamental reevaluation.
Absolutely, because we're realizing how it reacts continuously to environmental triggers. We're taking a condition that has traditionally been isolated to, ear doctors, and recognizing that its primary driver in a lot of chronic cases sits squarely in the realm of clinical allergy and immunology.
And that immunological driver is exactly what we are focusing on for today's deep dive. We are looking at otitis media with effusion, which is commonly abbreviated as OME, basically fluid in the ear.
Right, exactly.
We're going to explore its highly debated, yet, increasingly undeniable connection to allergic rhinitis. And the source material anchoring our deep dive today is this really groundbreaking 2025 position paper. It was published by the European Academy of Allergy and Clinical Immunology, the EAACI.
And it's important to note, this isn't just some fringe hypothesis.
Right.
This represents the synthesized consensus of over 50 leading rhinology experts, allergy specialists, and immunologists from all across Europe.
Over 50 top experts. That's huge.
Yeah, the interdisciplinary nature of this consensus is what makes it so robust. They're actively challenging decades of entrenched, siloed medical dogma.
Because everyone used to stay in their own lane, right? The ear doctors didn't talk to the allergy doctors.
Precisely. And this paper is demanding we look at the entire respiratory tract as a single, connected immunological organ.
Which brings us to our mission today. We are going to unpack this whole unified airways model. We'll look at why current clinical guidelines might be treating these chronic ear issues completely wrong. I mean, leading millions to rely on medications that are not only statistically useless, but potentially harmful.
Yeah, the medication data is pretty shocking.
It really is. And finally, we're going to explore how targeting a completely different phase of the immune system might be the key to permanently curing what we always thought was a structural surgical issue. So, okay, let's unpack this.
Let's do it.
To really grasp the mechanics at play when, an allergic reaction hits the ear, we have to start by completely redrawing our anatomical map of the human face.
We really do. We need to just throw out the compartmentalized boundaries that have dominated medical education for, forever.
Right, because historically, doctors split it all up.
Exactly. You had the lower respiratory tract, the upper respiratory tract, and then the middle ear was treated as this distinct, isolated chamber encased in the temporal bone. It was essentially treated like an anatomical island.
But the EAACI paper dismantles that island concept completely, right? They call it the unified airway model. So under this framework, the middle ear isn't an outlier at all. It's fully integrated into the respiratory system.
It is. And the embryological data they cite makes this just impossible to ignore.
Because of how we develop in the womb.
Right. When we trace the developmental biology, the tissue lining the ear cavity originates in the exact same embryonic ectoderm as the upper airway.
So it's the exact same starting material.
Yes. And if we connect this to the bigger picture, shared embryological origins dictate shared cellular behavior later in life.
Okay, that makes sense.
Because they differentiate from the same primordial tissue, their cellular makeup remains identical in the fully developed human. It's a continuous lining from the nose, through the nasopharynx, up the Eustachian tube, and right into the middle ear.
And they all have the same specific type of cells, right?
Yeah, it's all ciliated, pseudostratified columnar epithelium. which just means it's heavily populated with mucus-secreting goblet cells and tiny hairs called cilia.
The structural continuity is flawless.
Yeah.
You basically have this unbroken mucosal blanket stretching from the tip of your nose deep into your skull.
Exactly.
There is a quote in the paper from researchers Hurst and Bench that I think perfectly reframes this. They suggest we should think of the middle ear simply as the fifth sinus, which happens to harbor the organ of hearing.
I love that quote. Calling it the fifth sinus fundamentally alters how a doctor should approach it.
Right, because how do sinuses work?
Well, in a standard paranasal sinus, the primary defense is the mucociliary unit. It traps inhaled dust and microbes in the mucus layer, and those tiny hairs, the cilia, beat in coordination to sweep all that debris away.
Like a microscopic escalator.
Yes, and the middle ear relies on that exact same clearance mechanism.
But I have to push back on this a little, or at least on the timeline of this realization, because, the historical disconnect is baffling.
It is frustrating, yeah.
If the tissue is identical, and they developed from the exact same cells, why did it take modern medicine so long to treat them as connected? It's like a structural engineer failing to realize the plumbing in the bathroom is connected to the same main pipe as the kitchen, meaning a leak in one ruins the other.
Well, it comes down to the limitations of standard clinical observation. It kind of masked the functional reality.
What do you mean?
Anatomically, the middle ear is hidden behind the tympanic membrane, the eardrum. When a doctor does an ear exam, they look in with their scope and they see a physical barrier.
Right. They see the drum and they stop.
Exactly. They don't see the continuous tract behind it. That bony separation and the physical membrane create a highly convincing illusion of an isolated, closed-off room. For decades, medicine prioritized that macroanatomy over what the cells were actually doing.
Out of sight, out of mind.
Pretty much. But functionally, an inflammatory response in the nasal cavity doesn't respect those anatomical borders. A systemic disruption in the nose profoundly alters the microenvironment of the middle ear.
So, understanding that the ear operates as a highly specialized sinus, let's examine the actual condition, OME, itself. Particularly why it often flies completely under the radar until kids start having major developmental delays.
Yeah, so otitis media with effusion is characterized strictly as a non-purulent middle ear secretion.
Meaning it's not infected with pus.
Right. It lacks the acute bacterial drive that causes the classic painful ear infection we usually think of. Because it's not an acute infection, it completely bypasses the local pain receptors.
Wow.
Yeah, there's rarely any fever, no acute ear pain, and no severe redness of the eardrum.
It's totally silent, and that silent nature is what makes the numbers in this paper so concerning. The paper notes that 40% to 50% of OME cases are entirely asymptomatic and go undetected.
That's nearly half the cases.
Which means we are talking about millions of patients with this persistent fluid just sitting in their fifth sinus completely unaware. And the stakes here, especially for kids, are staggering. The paper calls it the leading cause of hearing impairment and language development delay in industrialized nations.
The developmental cascade triggered by this chronic fluid is severe. The presence of the fluid dampens the acoustic vibration of the eardrum and the tiny bones in the ear.
So everything just sounds muffled.
Right. And if a child experiences this persistent hearing loss during critical neurological windows for language processing, it fundamentally impairs their phonetic acquisition.
They literally can't hear the specific sounds of words.
Exactly. And this cascades directly into reading difficulties, reduced educational attainment, and sadly, significant behavioral misdiagnoses.
Just think about how many kids are flagged for, learning disabilities or ADHD when in reality, they just can't hear the teacher because they have asymptomatic fluid in their fifth sinus.
It's a tragedy. And traditionally, the pediatric approach to managing this has been remarkably passive, operating on a very narrow assumption of what's causing it.
Right, the traditional etiology. What have doctors been blaming this on?
The standard model almost exclusively blamed transient viral infections, like a common cold or simple mechanical dysfunction.
But just bad anatomy.
Yeah. The theory was that a virus causes temporary inflammation, or enlarged adenoids physically block the Eustachian tube. It was viewed purely through a biomechanical or infectious lens. It left absolutely zero room for a chronic, localized immune response.
Which brings us to the core thesis of the EAACI consensus. If OME is everywhere and it's driving this massive wave of developmental impairment, the mechanical and viral model just doesn't fully explain why it sticks around for so long in so many people.
No, it doesn't hold up.
This is where the paper brings in the allergy data, and it forces a complete reevaluation. First, we have to look at how common allergic rhinitis is now. Globally, it affects 15% to 25% of the population.
And in European cohorts, the prevalence is even higher, up to 30%. The paper highlights German demographic data showing that sensitization to common aeroallergens, things like house dust mites, pollens, animal dander, it's currently at 33.6%.
Over a third of the population.
Yes, when a third of the population carries a hyperreactive immune system, we have to meticulously analyze the comorbidities. What else are they suffering from?
And that comorbidity data is impossible to ignore. The studies show that 30% to 50% of children with chronic middle ear fluid also have allergic rhinitis.
It's a massive overlap.
And it goes beyond just a casual link. Atopic or allergic children carry a 2 to 4.5 times higher incidence rate of OME compared to healthy kids.
The allergic phenotype is a huge risk multiplier. Furthermore, the allergy actually dictates the severity of the disease.
Oh, really? How so?
There was one targeted screening of 310 pediatric patients. It demonstrated that among the allergic group, nearly 80% presented with bilateral OME, meaning the fluid was in both ears simultaneously.
Wow, both ears.
Yeah. In the non-allergic group, having it in both ears only occurred in 56% of cases.
So allergy makes it much more likely to take out your hearing on both sides. There's another study here that isolates the variable perfectly. They looked at kids with and without allergic rhinitis, AR. In a study held with AR, 7.5% had silent OME. But in the kids without AR, only 1.6% had it.
We are looking at nearly a 5-fold increase in fluid risk solely based on whether the kid has allergies.
But, okay, I want to play devil's advocate for a second here.
Sure, go ahead.
Because the paper also points out a paradox that skeptics love to use. They looked at a massive data set of 1.5 million kids, and it showed a really strong link between allergies and OME in kids age 6 and older.
Right.
But in the kids younger than 6, that strong association basically vanished. If allergy causes it, why doesn't it show up strongly in the younger kids? Doesn't that break the whole theory?
That's a great point, and this raises an important question about how our physical growth masks underlying diseases. We can't look at the allergy data without overlaying the physical development of a child's skull.
Okay, the skull development.
Yeah. In early childhood, the Eustachian tube is anatomically immature. It's significantly shorter, the opening is smaller, and crucially, its trajectory is almost entirely horizontal.
Because their heads haven't elongated yet.
Exactly. Because it's horizontal, gravity doesn't help it drain at all.
Yeah.
So any standard viral challenge like the common colds toddlers get constantly, easily overwhelms the system.
So the physical anatomy is just so bad at that age that it fails regardless of allergies.
Precisely. The sheer anatomical disadvantage means viruses and mechanical factors completely dominate in toddlers. The structural plumbing is just so prone to failure that it statistically drowns out the allergic variable in the data.
So the toddlers do have the fluid, but the main cause is just the flat tube failing, which masks the allergy data.
Exactly. But as the skull grows, everything shifts.
Right, because the midface elongates and that Eustachian tube drops to like a 45-degree downward angle.
Yes. Gravity kicks in, and the incidence of purely viral or mechanical OME plummets. Therefore, if a child who is 6 or older continues to have chronic ear fluid, the bad plumbing excuse doesn't work anymore.
Because gravity should be draining it.
Exactly. At that age, persistent fluid requires an active, localized inflammatory driver to overcome the mature anatomy. The structural mask falls away, and the allergic phenotype is revealed as the primary engine driving the chronic fluid.
That perfectly reconciles that data discrepancy. I love that. The mature anatomy should clear a normal cold. If it can't, something is actively hijacking the system.
Yes.
So, what does this all mean for the listener? To understand how inhaling dust in your nose actually hijacks a perfectly angled tube in your head, we have to look really closely at the Eustachian tube itself.
The Eustachian tube is the critical bridge. It's a functional linchpin of this unified airway. Its job is to regulate air pressure, protect from loud sounds, and actively drain the middle ear fluid via that mucociliary transport we talked about.
Right. And Eustachian Tube Dysfunction, or ETD, is the direct precursor to getting that fluid buildup.
Yes. And the mechanism by which allergies induce ETD is purely inflammatory. When the nasal lining encounters an allergen, it triggers an immune cascade that compromises the tissue barrier.
It swells up.
Significantly. And because the tissue is continuous, this swelling doesn't stay isolated in the nose. It literally physically creeps up into the nasopharynx, directly engorging and blocking the opening of the Eustachian tube.
Okay, so I picture the tube as this, microscopic escalator meant to carry trash, meaning mucus, down and out. But an allergic reaction essentially throws a giant mattress onto the bottom of the escalator, jamming it completely and causing a backup all the way up into the ear.
That is a perfect analogy. It creates a critical mechanical obstruction at the bottom. But the dysfunction is also chemical.
Chemical? How?
The allergic reaction releases pro-inflammatory mediators, cytokines. These travel up into the tube and directly paralyze the cilia, those tiny hairs on the escalator. It also makes the mucus thicker, essentially freezing the clearance mechanism.
The paper actually proves this with tubomanometry data, right?
Yes, tubomanometry. It objectively measures how well the tube opens.
And they looked at patients with just house dust mite allergies. The data showed 33.9% of the allergic patients had severe Eustachian tube dysfunction, compared to just 5.9% of healthy controls. The allergic response is functionally paralyzing the tube.
It's undeniable. And this systemic view also perfectly explains why a very common surgery for this often fails.
You mean removing the adenoids?
Yes, adenoidectomy. Children with allergies often get enlarged, hyperplastic adenoids, because the chronic allergen exposure keeps that immune tissue inflamed. Right. The traditional surgical approach views the enlarged adenoid as just a simple physical block over the tube. The logic is simple. Cut out the adenoid, unblock the tube, fix the ear.
But the EAACI consensus explicitly notes the high failure rate of doing that in allergic kids because looking through the unified airway lens, the surgeon removes the physical tissue but completely ignores the underlying immune reaction.
Exactly. The patient recovers, goes home, breathes in dust mites, the mucosal swelling returns, the chemical cytokines continue to paralyze the cilia, and the ear fluid comes right back. The surgery treated a symptom, not the root cause.
Wow. It's so frustrating to think about how many kids go through surgery for nothing. But here is where we need to dive even deeper. We've seen the macro blockage, the swelling, but what is happening at the microscopic cellular level inside the middle ear when exposed to an allergen?
What's fascinating here is how this shifts the burden of proof. For decades, skeptics argue that the allergy was strictly in the nose, and the middle ear was just a passive bucket catching the backed-up fluid.
Just an innocent bystander.
Right. But advanced biochemical analysis of the actual ear fluid destroys that passive bucket theory. Researchers are finding the exact molecular signatures of an active, localized allergic reaction happening directly inside the middle ear cavity.
They actually sampled the ear fluid and found Th2 cytokines, activated eosinophils, and mast cell mediators directly in the cavity.
Yes, they did.
They even found that levels of mast cell myeloperoxidase, which is a direct marker of an allergic reaction, are significantly higher in allergic kids' ear fluid. The fifth sinus isn't just a victim, its own tissue is actively fighting an allergic attack.
To understand the damage here, we have to differentiate between the early and late phases of an allergic response.
Okay, break that down for us.
The immediate early phase reaction is driven by histamine. That causes the acute swelling, the runny nose, the sneezing right after you pet a cat, for example.
The classic allergy symptoms.
Exactly. But the chronicity, the reason OME sticks around for months, is driven by the late phase response. This peaks hours later and involves a massive influx of white blood cells called eosinophils into the tissue.
And when researchers look at chronic OME fluid, it matches this late-phase eosinophilic profile perfectly. They find these highly specific toxic proteins released by these cells, specifically eosinophilic cationic protein, or ECP, and major basic protein, MBP.
And this is where the immune system's response becomes incredibly self-destructive. ECP is essentially a toxic biochemical weapon. It's designed by the body to dissolve the cell walls of invading parasites.
But there's no parasite here. It's just pollen or dust.
Exactly. So in the absence of a parasite, that toxicity is unleashed directly on the host's own tissue. The ECP aggressively degrades the lining of the middle ear and actively destroys the microscopic cilia.
It's like a friendly fire incident. The immune system sends in heavy artillery, the eosinophils, to fight a harmless dust mite, but the shrapnel, the ECP, destroys the very cilia trying to keep the ear clean.
That's exactly what happens. The immune system chemically burns away the exact microscopic infrastructure needed to drain the fluid.
Unbelievable. And this compromised, burned-out environment creates a perfect storm for bacteria, doesn't it? The paper talks about a 1-2 punch, because bacteria are found in over 70% of kids' ear effusions.
Yes. Historically, that high bacteria rate led doctors to assume OME was just a persistent, low-grade bacterial infection, which is why they threw so many antibiotics at it.
Right.
But the EACI paper details how chronic allergic inflammation actually weakens your natural defenses. The constant allergic cascade lowers the production of antimicrobial peptides, leaving the ear highly vulnerable to normal opportunistic bacteria.
The allergy basically lowers the shields, letting bacteria move in.
Exactly. And to prove how explosive this combination is, the paper details this amazing yet terrifying mouse model.
Oh, the LPS study. Walk us through that.
Right, so researchers wanted to isolate what happens when an already allergic ear gets exposed to bacteria. They use lipopolysaccharide, or LPS, which is a highly inflammatory component found on the outside of certain bacteria. They injected this LPS directly into the middle ears of mice.
Okay.
The control group of normal, healthy mice just mounted a standard temporary immune response and cleared it up. But the experimental group of mice had been previously sensitized to have an allergic phenotype.
They made them allergic first.
Yes. And when those allergic mice were challenged with the bacterial LPS, the results were catastrophic. 100% of the allergic mice developed severe, prolonged otitis media with effusion.
100%. All of them.
All of them. It wasn't just an additive effect. The underlying allergy primed their immune system to hyperreact. The bacterium triggered an intense, uncontrolled cytokine storm inside the ear. The allergy turned a manageable bacterial encounter into a massive, sustained inflammatory disaster.
All right.
And the paper notes that the pathology in those mice looked exactly like severe asthma in the lungs. It proves the ear is capable of mounting an asthmatic-level reaction.
It absolutely is.
Which brings us to perhaps the most frustrating aspect of this entire deep dive. If the data is this definitive, I mean, we have the ECP, the cytokines, the 100% mouse models, the 1.5 million patient data sets. Why is this still debated? Why do so many doctors still miss the allergy connection?
Because, simply put, the clinical consensus was blinded by broken testing methods. Doctors have been using the wrong diagnostic tools for 50 years.
Here's where it gets really interesting for the listener because it's a diagnostic blind spot. The paper calls OME a low-level IgE disease.
Right. In a classic systemic allergy, like a severe peanut allergy, if you draw blood, you will see a massive spike in total circulating IgE antibodies everywhere in the body.
But OME isn't like that.
No. The immune activity in OME is intensely localized just to that unified airway tissue. The actual ear fluid has IgE antibodies, but it's often below 100 milligrams per liter. It's a smoldering, highly localized reaction.
And crucially, this local reaction operates almost entirely independent of the total IgE circulating in the peripheral blood, which is where the testing completely failed.
Exactly. For half a century, the absolute gold standard for diagnosing allergies in a clinic has been the skin prick test.
They scratch your back or arm with the allergen?
Right, the epicutaneous test.
Yeah.
And that test relies on detecting systemic IgE bound to cells in the skin. Because OME is driven by this low-level, localized mucosal IgE, the skin cells simply don't have the sensitization to react.
They don't know what's happening in the ear.
Exactly. The EAACI paper reveals that standard skin prick tests return false negatives in up to 80% of confirmed allergic OME cases.
80%. That is a staggering failure rate. Just imagine decades of clinical trials. Researchers wanted to see if allergy meds help OME. They recruit a bunch of kids with OME, screen them with a skin prick test, and boom, 80% test negative for allergies.
So the researchers classify them as non-allergic.
The data skews, and the published paper says, nope, no link between allergies and OME. Entire generations of medical consensus were delayed because they were using a test that wasn't sensitive enough to catch the culprit.
It is a profound failure of clinical methodology.
So if the superficial skin prick test is useless here, what is the solution? How do we actually diagnose this?
The EAACI consensus points directly to intradermal dilutional testing, or IDT.
How is that different?
Instead of a superficial scratch, IDT involves injecting the diluted allergen slightly deeper directly into the dermis. This exposes the allergen to a much denser and different population of immune cells and deeper blood vessels.
Okay.
This deeper tissue penetration captures that localized mucosal immune memory far more effectively than a surface scratch.
And the statistical difference is wild. When researchers switched from the PRINT test to IDT, diagnostic accuracy skyrocketed. Suddenly, 72% to 100% of the OME patients were correctly identified as allergic.
In one specific study, the intradermal method identified 57% more allergic OME patients than the scratch test.
So the mandate from the experts is clear. For persistent OME, especially in kids aged 3 to 6, a basic ear exam isn't enough. Doctors must look beyond the standard prick tests and use IDT or nasal provocation tests, where they put the allergen straight into the nose to measure the localized reaction.
It's absolutely mandatory, because securing an accurate diagnosis completely rewrites how we treat the patient. Right now, millions of people are taking the wrong medications.
Let's talk about those therapies. Armed with the right diagnosis, how do we fix this? Because the paper reveals a lot of popular treatments are entirely useless.
Systematic Cochrane reviews and the 2017 International Consensus explicitly advise against using a whole list of common drugs: systemic steroids, oral antibiotics, decongestants, and oral antihistamines.
Wait, antibiotics and antihistamines, those are the exact drugs doctors always prescribe for ear fluid.
I know, but they are universally condemned for OME by this consensus. They have absolutely no statistically significant clinical benefit for resolving the fluid, and yet they carry an 11% side effect rate.
So you're taking a 1 in 10 chance of a bad side effect for a drug that mechanically cannot fix the problem.
Exactly. And the failure of oral antihistamines is a perfect example of why we have to understand the mechanisms. Patients get diagnosed with an allergy, they take Claritin or Zyrtec, and the ear fluid doesn't budge. They get frustrated.
Why doesn't it work?
Because antihistamines only block the immediate early phase histamine release.
Right. It's like trying to put out a campfire after the forest is already burned down. The initial spark, the histamine, is gone. You're dealing with the smoldering ash, the eosinophils. Systemic antihistamines do absolutely nothing against that late phase eosinophil attack.
That's exactly right. They are targeting the wrong biochemical phase of the immune response.
So if pills don't work, what's the standard of care?
For non-allergic OME, it's mostly watch and wait, saline irrigation, or eventually surgical grommet insertion. They cut a hole in the eardrum and put in a tiny tube.
But the EACCI consensus does suggest a pharmacological trial before going straight to surgery for allergic kids, right? Intranasal corticosteroids.
Yes, INCS. It's a bit controversial in the broader literature, but the panel recommends trying it. The goal is to aggressively spray a topical steroid directly into the nose and nasopharynx to forcefully shrink the swelling around the Eustachian tube opening.
Just manually force the swelling down so it can drain.
Right. Give the intrinsic clearance a chance to recover. But even that is just palliative. It suppresses inflammation, but doesn't change the underlying allergy.
Which brings us to the magic bullet. The intervention the paper highlights as a genuine, permanent fix. Allergen immunotherapy, or AIT.
AIT, which is administered through allergy shots or under-the-tongue drops, is the only treatment that alters the fundamental immunological software of the patient.
How does it do that?
By exposing the immune system to tiny escalating doses of the specific allergen, like house dust mite extract. It induces tolerance. It shifts the entire cytokine profile away from that destructive Th2 response and literally retrains the immune system to ignore the allergen.
And the clinical outcomes for OME are just incredible. The paper details this landmark study of 89 OME patients. And these weren't mild cases. These patients were so bad they warranted surgical ventilation tubes, or they already had chronic drainage from ruptured eardrums.
They had completely exhausted standard medical options.
Right. So the doctors gave them targeted AIT based on their specific allergies. The result: 85% achieved complete resolution of their effusion or drainage. 85%.
Completely negating the need for surgical intervention.
And it was fast. Children under 15 achieved complete resolution within just 4 months of starting the therapy. More importantly, they remained completely disease-free for the entire 2 to 8 year follow-up period.
This data is the ultimate validation of the unified airway model. Rather than surgically cutting into a child's eardrum, you use immunotherapy to desensitize them to the dust mites.
You completely short-circuit the whole cascade.
Yes. You prevent the initial swelling, you stop the late-phase eosinophils, you save the cilia from being destroyed by ECP, and you allow the tube to naturally regain its function. You are permanently resolving a physical structural issue by fixing an immunological error.
It is brilliant. It perfectly shows why treating the root cause is so vastly superior to just managing the downstream symptoms.
Absolutely.
We have covered a tremendous amount of complex ground today. To quickly summarize, the ear is functionally a sinus. Allergies cause inflammation that doesn't respect anatomical borders. That inflammation travels up the Eustachian tube, physically blocking it and chemically paralyzing it with late-phase immune responses.
And we have to remember that standard allergy scratch tests miss this 80% of the time, requiring deeper intradermal testing.
Right. And finally, treating the root allergy with immunotherapy can literally save patients from unnecessary surgery and permanent hearing loss.
It's a total game changer.
It really is. But to wrap up this deep dive, the EACI paper leaves us with one incredibly provocative, lingering thought about the future. They explicitly note that modern environmental factors, specifically worsening air quality and escalating pollution, are proven to negatively impact Eustachian tube function and weaken our innate viral defenses.
It's a really toxic combination.
Because we have up to 30% of Europe now sensitized to these allergens. The baseline inflammatory burden on our respiratory system is unprecedented. So you have to ask yourself, are we witnessing an evolutionary mismatch?
That's a profound way to look at it.
As our environment becomes more polluted and pollen-heavy, and as our immune systems become more hyperreactive, our human faces and our delicate fifth sinuses simply no longer structurally equipped to drain properly in the modern world. Have we chemically outpaced our own anatomy?
It certainly seems like we might have.
The next time you experience that dense, unyielding pressure in your ear, consider that it might not just be a simple plumbing failure. It might be your unified airway signaling that it is fundamentally overwhelmed by the modern world. Thank you for joining us on this deep dive.